Another video for pericardial disease based on the ACC 2025 guidelines that just came out this year. So the first thing for understanding pericardial disease, you have to understand like the anatomy of that. Pericardium consists in two layers, parietal layer and visceral layer. Parietal layer is the outermost layer, is the external layer, composed of fibrous mesothelial cells, and visceral layers, which is a serous membrane. In between, you're gonna have a 20 to 50 ml of like a fluid, which is a serum of ultrafiltration of the serum. This is drained by lymph nodes. Acute pericarditis is an inflammation, cell-limited. It represents like a 5% of all chest pain visit to the ER, and 0.1% are gonna be hospitalized, really a pretty low number. 50 to 30%, 3 out of 10 are gonna have recurrence. How we are gonna suspect recurrence is, especially like if the patient doesn't have a response to NSAIDs, early use of steroids, high inflammatory markers such as CRP, and severe left gadolinium enhancement. Acute pericarditis could be isolated or manifestation as systemic disease. For example, lupus erythematosus is going to present with acute pericarditis. The first thing that you have to recognize is chest pain. What is the chest pain characteristic of chest pain? Why? Because that is going to give you a clear path to the diagnosis of acute pericarditis. The chest pain is usually sharp, rapid onset, improve with sitting up and leaning forward, and it's pleuritic. For example, you are going to ask the patient take a deep inspiration. The patient breathe in, and is that cause like exacerbation of the pain. Probably that is a pleuritic chest pain, and radiate to the back through the trapezius. So if you have those characteristics, that is telling you that this chest pain may be likely due to acute pericarditis. Physical exam, sinus tachycardia, low-grade fever. You may hear like a rub. That is difficult to hear, by the way. Also, you may have like weight loss, night sweats, rash, or arthritis. EKG is important. Why? Because this is the first diagnostic tool. Usually, PR depressions and ST segment elevation. These ST segment elevation are concave. What is concave? Meaning like it's going to be a happy face. Then you're going to have T-wave inversions, and then the EKG is going to recover like in the subsequent weeks. This is a specific, by the way, is specific. What does it mean? Specific? If you have it, you have it. What it means is no, but this is not sensitive, meaning like a patient may not have these findings in the EKG. If you ask elevated troponins, why? Because you can have involved myocardium. Is a 15% of all pericarditis going to have involvement of the myocardium. Also, echocardiogram is going to, or imaging, whatever imaging tool that you use, you can have a dysfunctional, systolic dysfunction of the LV. Perimyocarditis and myopericarditis are same thing. Perimyocarditis, myocarditis is dominant, and myopericarditis, pericarditis is dominant. So keep in mind those terms. 2015, the European guidelines came with a criteria. 2 out of 4, you diagnose acute pericarditis. Chest pain, characteristic chest pain, pericardial rub, EKG, and new or worsening pericardial effusion up to like 60%. If you have like 2 out of 10, 2 out of 4, you have a pericarditis. They also like tell you like that wasn't part of the criteria is elevated inflammatory markers and imaging, but wasn't part of the criteria. Now, 2025, ACC came out like, okay, those now are part of the criteria. You start with a typical chest pain, and if you have like one of those signs, you may have a pericarditis. Well, pericardial friction rub, EKG changes, inflammatory markers, imaging of a worsening pericardial, of new or worsening pericardial effusion, or cardiac evidence of inflammation, such as left gadolinium enhancement. If you don't have any of those, you don't have, it's unlikely that you have like pericarditis. You have one, for example, you have only elevated markers. It's possible. Why? If you have two, is a diagnosis, definite diagnosis of your pericarditis. For example, patient comes to the emergency department. Typical change of pericarditis is pleuritic, improved with leaning forward and sitting up, is sharp, but you only have EKG, you only have like inflammatory markers, that's possible. If you have like EKG inflammatory markers, that's definitely diagnosis. If you have like a effusion inflammatory markers, that's too. So the duration is important. Duration acute is 4 to 6 weeks, didn't change. Incessant, lasting more than 4 to 6 weeks. Chronic, lasting more than 3 months. And recurrent is already this episode subside, meaning like resolve, and then you have like after 4 to 6 weeks another new episode. What is the etiology? You're gonna have like a bunch of like causes that may lead to acute pericarditis, but the etiology most common is idiopathic. Idiopathic is meaning we don't find the cause. Then, if you are in a low resources country, always think of TB, maybe due to HIV. That's why like the patient comes from a low resources country, always think on TB. High resource countries, most likely viruses. What's important is to understand is why, because in the physical, when you are doing like your history, always ask, do you have like a flu-like symptoms? And do you have like a GI symptoms before this episode of chest pain started? And the patient tell you yes, uh, probably like it's most likely a viruses. Also, like it's common nowadays to a lot of patients to have like any cardiac uh, interventions such as TAVR, PCI, pacemaker, etc. That is also can give you can cause like a acute pericarditis. This is called like post cardiac injury syndrome. So always ask, do you have like recently a PCI, pacemaker, ablation, surgery such as CABG? Another common cause is autoimmune disease, hypothyroidism, always has labs, TSH, and also like cancer, radiotherapy, immune checkpoint inhibitor. Also, other causes such as uremia, if the patient has dialysis, so is important causes of like acute pericarditis. So remember, most likely is idiopathic. If the patient comes from a low resources country, always think on TB. If the patient comes with a high, is patient is in like a high resource country, most likely viruses, but also like post cardiac injury syndrome, which for me is important. Why? Because many patients may have like some cardiac intervention. What is the classification? The classification is important for the management. You are going to classify the inflammatory and non-inflammatory. Inflammatory meaning there is inflammation, elevated markers on inflammation, CRP, high fevers, WBC, ESR, or also if you do a cardiac MRI, you're going to have like a pericardial inflammation, late gadolinium enhancement. Non-inflammatory, normal or low CRP. Usually this is because of autoimmune disease. Is non-inflammatory is 10 to 20%. So what imaging modalities they recommend? They recommend echocardiogram, MRI, CCT, if indicated. Echocardiogram, the first tool, is recommended, highly recommended. Why? Because it's easy to do it. Is 40%, remember, is going to be normal. Pericardial effusion, you are going to evaluate pericardial effusion. Very large, more than 25, large, more than 20, small, less than 10 centimeters, 10 millimeters. You can also evaluate the involvement of the myocardium, how you're going to have dysfunction of the LV, or you can do like a global longitudinal strain, where if it is lower, that can hint as myopericarditis. Myocardium is involved, especially with the elevation of the troponins. This is pictures of like how like the pericardial effusion is found. This is a small in image A. This is a moderate, and this is a large, very large pericardium. Cardiac MRI is a second line. They recommend it when when you have like a complicated case, when the pericarditis is incessant. Incessant meaning like doesn't resolve after 4 to 6 weeks. When it's recurrent, when it's chronic, when there is any doubt about the diagnosis, when the myocardium could be involved, when there is like a complications, for example, complex effusion or constriction, you're gonna have like late gadolinium enhancement. Why is this late gadolinium enhancement happens? Why? Because the pericardium doesn't have vascularization. It's gonna be now with acute pericarditis neovascularized. The sensitivity is a 94%, Also help you with the staging, acute, subacute, or chronic. Prominent left gadolinium enhancement with increased sign of the T2 signifies acute. Chronic is answering of a T2 sign signal, and subacute is already normalizing like the T2 signal. So remember, cardiac MRI is recommended when you have like complicated cases, and it's not recommended when you have like uncomplicated cases for acute pericarditis. For example, patient comes is the first time it's a classical acute pericarditis. You have like a echocardiogram tell you like a mild, trivial pericardial effusion. You may not need like a cardiac MRI, but you may need a cardiac MRI when the patient comes with cardiogenic shock. You suspect myocarditis, elevated troponin, like a coronary is claimed. Probably a cardiac MRI is a good tool to have on this position. And how you're gonna assess severity based on the cardiac MRI. It's pretty straightforward. So first of all, you have to have this short axis, 50% of this circumference affected, and 3 millimeters of the thickness of left gadolinium enhancement. Based on those two criteria, and based on like the slices, the numbers of slices that you have, basal, middle, and apical, based on the three criteria, you are going to have a different, no, mild, moderate, and severe. For example, severe is you have like more than three slices, you have like more than 3 millimeters of thickness, or you have like more than 50% of circumferential is severe. No, you don't have anything. And in between is mild and moderate. Moderate, less than 50%, but you have like 3% of like the thickness, or in three slices, basal, uh, middle, or apical slices. This is pretty straightforward to understand. For example, here we have like involvement in imaging B of the whole pericardium. This is involvement. And imagine you have like in three slices, and this measure more than 3 millimeters, you have like severe involvement of the pericardium. And you can hear here the enhancement. Now, CT. CT is not recommended for routine assessment of pericarditis, such as like MRI, but it's reasonable when you are suspecting other causes of chest pain, for ruling out other causes of chest pain. Also for complications, for example, like you are suspecting calcification, or you're suspecting you are gonna do a surgery for a pericardiectomy pre-op planning. Also, it's important because you may have you can evaluate the fluid as well based on the Hunsford units. Transudate, exudate, is hemorrhagic, and Kilios. And you can here have like the numbers. Transudate is like 0 to 20, exudate 20 to 50, hemorrhagic more than 50, and Kilios more than 60. You can evaluate like the pericardial thickening, calcifications, chamber cortification, etc. The only problem is like the CT is not going to give you like the motion normally, so you can evaluate pretty much the myocardium pretty well here. But it's a great tool that you are suspecting calcification, or you're suspecting all the reason for the chest pain. For example, like a PE, so you can do like a CTPE with contrast, and you can evaluate the pericardium, the same imaging tool. Different diagnosis, differential diagnosis, especially there is like there is only coronary artery disease, myocardial infarction. That's why myocarditis, acute pericarditis. That is the differential diagnosis. This is straightforward when you have like a patient with a chest pain. Always think like, what is the coronary involvement of chest pain? Worst prognosis is important to recognize this, because that is going to tell you like a likelihood of complications. Patient has high fever, subacute course, large effusion. Remember, large effusion more than 20 centimeters in the echocardiogram. There is a tamponade physiology that is tell you like by itself like this is like a worse prognosis. Lack of response after 1 week. There is involvement of the myocarditis. Also, immunosuppression, trauma, or oral anticoagulation. The patient is taking those, or have like immunosuppression. That is worse prognosis. Treatment. how we're gonna manage acute pericarditis. The first thing we have to understand what is the pathophysiology of inflammation here in myocardium. Everything is going to start with DAMPs and PAMPs, which is those molecules that are going to stimulate like toll-like receptors. Those are going to stimulate like the nuclear factor line change, and that is to the nucleus is going to increase those markers. And those markers, for example, like a procaspase 1, are gonna stimulate the liberation of interleukin 1b and interleukin 18. So we have like different medications that can like attack those. Also like phospholipase A2. For example, like the common one is aspirin NSAIDs. Those are gonna decrease the production of prostaglandins, thromboxanes. Also colchicine, a well-known medications, is gonna decrease the aggregations of like neutrophils. Corticosteroids helps the same way like NSAIDs decrease like the phospholipase A expression that is going to decrease arachidonic acid and prostaglandin or thromboxane like expression. Corticosteroids also like corticosteroids also like can influence in like the decrease of expression of like the nuclear factor. And we have like immunologics that acts in the receptors. It's, anakinra and rhinolacept. Those are pretty new medications. So in this slide tells like all the tools that we have for management the acute pericarditis. And the first line is always going to be NSAIDs or aspirin plus colchicine and exercise restriction. The second line, we have like immunologics such as rilonacept or anakinra. Remember, those acts on the receptors for interleukin 1. Steroids or the remaining like tools that we have, like a radical pericardiectomy, or always important treating underlying etiology. We're going to talk more about this in the next slides. So initial treatment, NSAIDs, aspirin plus colchicine. If there is response, we're going to tapering over the weekends, over the remaining following weeks. It is no response, we have to see like if this is inflammatory type. How we recognize inflammatory type, elevated markers, CRP. Yes, we're gonna add like a anti-interleukin 1, for example, like anakinra, rhinolacept. It is no, we're gonna consider steroids. And sometimes we can consider those anti-interleukin 1 in those patients as well. And then if there is refractory to those treatments, we may have to consider radical pericardiectomy. So the first line that we're gonna use with a patient with acute pericarditis, always a colchicine. For 3 months, it is acute. 6 months, it is recurrent. Then NSAIDs or aspirin. And we're gonna start with a high dose and tapering after the resolution of the symptoms and normalization of markers. If you are going to use a NSAIDs or aspirin, consider PPIs like the protonics. Prophylaxis for colchicine, meaning like imagine like the patient goes to a cabbage. It's not well defined, so they don't touch base on this. It is recommended or not. What is recommended if you have like a first time like a diagnosis of acute pericarditis is exercise restriction for more than a month. Why is that? Because if your heart rate goes above 100 beats per minute, your pericardium is going to be rubbing. So that's going to cause more inflammation. That is why, like, if the patient is a young patient, plays soccer or plays basketball, you're going to recommend stay away from exercise because that is going to increase the recurrence of acute pericarditis. Remember, less than 100 beats per minute. Now, this is important to understand. Imagine like the patient now comes for acute pericarditis that has like a atrial fibrillation, right? And is not in any medication. Probably you are gonna avoid the heart rate to go like you want like to avoid like the heart rate to go about like 100 beats per minute. Why? Because there is more rubbing. So you may prescribe some beta blockers for that patient in that context. Corticosteroids. Before it used to be like a second line But right now, usually is in those guidelines, they say like in some cases you can do it reasonable. For example, after failure of first-line therapies for current incessant pericarditis, especially without evidence of CRP, meaning it's non-inflammatory, because inflammatory consider those immunologics. So again, restrictory, how you're going to start is low, moderate doses of prednisone. For example, like a zero point 0.5 milligram kilogram daily. For example, usually it's 20, 15 to 20 daily, and you're going to tapering slowly for months. Also, like, don't forget, if you are going to use more than 20 milligrams of prednisone for more than 1 month, always keep in mind that you may have to consider prophylaxis for PCP, pneumatosis, or osteoporosis. Until anti-interleukin 1, such as like anakinra, those you may consider is inflammatory phenotype, meaning like CRP is more than 1. Those are preferred over steroids. When you are using those anti-interleukin 1, taper other treatment. For example, first steroids, second NSAIDs, and then colchicine. The duration is unknown. Why? Because there was like a trial, a Rhapsody trial, that they used Rhinolacept, and there was like a high recurrence of 50 to 70% of upon discontinuation of this drug. So the duration mm, uh, is not known, like how long the patient have to be on this medication, but they use like 18 months. So 18 months probably is the duration that they recommend or more, and that depends on like how recurrent is this acute pericarditis. Then other treatments as a thiopri and intravenous immunoglobulin, the patient who failed steroids and anti-interleukin 1, radical pericardiectomy. This is important. Why is that reason? Because imagine like the patient comes with a chest pain, acute pericarditis, it doesn't tolerate like the first treatment, which is like NSAIDs and colchicine. And the patient is a young female, and you start like anti-interleukin 1, and the patient is is doing great with this, but then the patient tells you like, oh, I want to become a mother, I want to be a pregnant. So maybe then you may consider radical pericardiectomy. And if you are gonna do surgery, this radical pericardiectomy, continue this treatment, steroids or anti-interleukin 1, for at least 3 to 6 months after the surgery. Right before the surgery, you stop it, like 3 to 6 months after you continue. And this is the dose that usually is recommended. Aspirin is 1,000 3 times daily, which is a high doses for those medications. Ibuprofen, which is commonly used, 6 to 800 3 times daily. I will tend to do like ibuprofen in the clinical practice. Why? Because it is easy to for the patient, right? And colchicine, remember, is zero point 0.6 twice daily or zero point 0.6 once daily. If like the patient is like less than 70 kilos, severe renal or hepatic impairment, 3 months acute, 6 to 12 months recurrent. Prednisone, we already talked about, zero point 0.2 to zero point 0.5 milligrams or kilogram. Those immunologic has their own regimen, usually are injectables. This anakinra is a daily, and these Rhinolacept are weekly, so you may consider like how the patient wants to do it. Radical pericardiectomy is always when those medications fails to control the acute pericarditis. So now complication. Complication is important to talk about. Why? Because we need to know how to diagnose and how to manage. Pericardial effusion, cardiac tamponade, constrictive pericarditis, effusive constrictive pericarditis. What is those terms implies? First, pericardial effusion, we already talked about it. What is recommended here is a echocardiogram for this. Cardiac tamponade, always echocardiogram. Constrictive pericarditis, you may use for this first echocardiogram, second like other tools such as like CCTA, such as like an MRI, but those are like a complication. Effusion constrictive pericarditis is when you drain already the fluid, but the constriction physiology it persists. So TTE identify pericardial effusion. You can use CCTA or cardiac MRI or transesophageal echocardiogram for diagnose this pericardial effusion when TTE is inconclusive. CCTA is not recommended for any remember for any like a classical acute pericarditis or routine assessment of cardiac tamponade that is recommended like an echocardiogram there. So this is important. Why? Because you are when you first encounter a patient with acute pericarditis, a classical symptoms, you're not gonna jump right straight to like a cardiac MRI. No, you're gonna do echocardiogram. Pericardiocentesis for any pericardial effusion, no. Always when you have tamponade. And if you have a huge pericardial effusion, it's better to start first with treatment and then to evaluate. Pericardial window, when you have like a multiple recurrent large pericardial effusion and cardiac tamponade. For example, the patient has a cancer, then you may consider pericardial window. So this is like is pretty straightforward. Why? Because that is gonna tell you like how you are gonna recognize constriction. And you're gonna start with mitral inflow. E over A prime is more than A, and dilated with inferior vena cava. Yes, there is a respiratory phasic ventricular septal motion. Yes, and you're gonna see the mitral E prime. More than 8, constrictive pericarditis, less than 6, restricting cardiomyopathy. And then you may have like annulus reversus. So it's pretty straightforward. This next slide, I'm going to explain you why is that. First, cardiac tamponade. We're going to talk about cardiac tamponade. Cardiac tamponade is important. Why? Because can cause cardiogenic shock. Why? Because the heart is equalizing pressures because of the pressure that is outside of the heart. How you diagnose is dilated IVC, is a high sensitivity. You're gonna have like diastolic RV collapse is the most specific. So why is a diastolic RV collapse the most specific? Why? Because the RV are gonna have a less pressure than the LV, but more pressure than the RA or the RA. So you are gonna see diastolic collapse, and that is tell you like, oh, when you have like diastolic collapse, there is no filling of the RV, there is no blood going to the left side, and there is no blood going to your body. What is the treatment for cardiac tamponade? Pericardiocentesis. Pericardiocentesis is the treatment for cardiac tamponade. Also, you can do an echocardiogram. It's not usually done this inflow transmittal more than 30%, like the E velocity or tricuspid more than 60%. Why? Because usually when you have diastolic RV collapse, it's more is highly specific, so you go like jump straight to the treatment, especially patient is hemodynamically stable. You can see here in the images, you have like diastolic collapse. In diastole, you have like the collapse. This is highly specific. You have to take it a for the draining of this fluid. And this is the respiratory variation with inspiration and expiration. It's more than 30% and more than 60% in the tricuspid. And this is a mitral, the tricuspid. Usually it's no done like most of the time. Why? Because when you have the this is specific and you have to drain this fluid. So inferior vena cava more than 2.1 without respiratory 50% of respiratory collapse. That is pretty sensitive signs, or you may have a cardiac tamponade. Now, constrictive pericarditis. Constrictive pericarditis is the pericardium is rigid, so doesn't allow the heart to expand. Could be transient or chronic. Chronic usually is calcified. For that, you have to do surgery. Could do what is the etiology? Idiopathic post-cardiac syndrome or radiation. That's why it's important always to ask if you have breast cancer, do you have like radiation or no? And TB always think in low resources country. Why is important? Because impairment of diastolic ventricular filling, the patient may have like signs of heart failure. The ejection fraction is going to be normal. Interventricular dependence. What is that? You have like the right, left side. in the ventricle is the only one who is moving. So in inspiration, the right side is going to move the septum to the left side. In expiration, because the blood is coming to the left side, the septum is going to move to the right side. And that is going to cause impairment of the filling of the either ventricle. So how you diagnose? Here you may have like a annulus reversus. What is mean annulus reversus? Normally, the lateral walls of the heart is going to be more mobile, and the medial is going to be more less mobile. So when you have like a constrictive pericarditis, now the annulus is going to be more mobile. It's going to move more than the lateral. That is an annulus reversus, so that can give you a hint of constrictive pericarditis. Also, remember late diastolic flow, expiratory reversal, and hepatic pain. Why is that? Is because in expiration, the blood is coming to the left side, it's going to cause like shifting to the right side, and you're going to have reversal in the hepatic pain. Plethoric of the IVC. This is sensitive for anything that impairs the filling of the ventricle, meaning tamponade, constrictive pericarditis. So what is recommended? Echocardiogram is recommended. Reasonable cardiac MRI if like the TTE is inconclusive. Cardiac MRI also can be helpful for pericardial effusion. CCT if you are suspecting any calcifications here. Invasive when all of these fail. What is the first line treatment of inflammatory constrictive pericarditis? Anti-interleukin 1. Why? Because it can decrease the constriction. Diuretics is recommended for symptom management, and then radical surgical pericardiectomy when those treatment anti-inflammatory with those anti-inflammatory doesn't work or is non-inflammatory and is chronic, then you may consider this. In radical, they are against a partial pericardiectomy. Back in the day, it used to be a partial, meaning only I'm gonna do the anterior, only I'm gonna do the diaphragmatic. Now it's radical. You have to like dissect all the pericardium around the heart. Remember this, when you may have also like a pregnant woman who has like a recurrent acute pericarditis, you may consider also pericardiectomy. Why? Because she may want to be pregnant and she would like to avoid any medication which could affect the fetus. The last slide showing the echocardiogram findings on constriction pericarditis. First of all, the IVC. IVC more than 2.1 and there is no respiratory variation, meaning like the size doesn't change with the respiration at least 50%. That tells you like is a sensitive marker of you may have like constriction pericarditis. Also, you may have like cardiac tamponade. So that is a sensitive marker. Why? Because many diseases that affects the feeling of the heart is going to have like these signs. Then you may have like annulus reversus. Remember, annulus reversus is normally the lateral and the medial wall, the tissue. The lateral is moving more. Why? Because it's friendly. But when you have a constriction, the lateral walls are attached to the pericardium, so it's moving less. So the medium is moving more. That's tell you annulus reversus and is a finding of constriction pericarditis. Then respiratory variation. Why is that? Inspiration, blood goes to the right side, septum shift to the left side. So the mitral valve is gonna change the E velocity, the filling velocity, more than 25%. When you have expiration, more blood to the left side, septum shift to the right side, more than 40% change in the tricuspid valve. Remember, in cardiac tamponade was like higher than that, was 30 and 60%. Now, also you can see like the hepatic pain. The hepatic pain, you have like a reversal in expiration in the endodiastole. As you can see here, those are reversals, diastole, expiration, and inspiration you're not gonna have that. Why is that? Because expiration, blood go to the left side, shift the septum to the right side, and that is gonna cause like a blood in late diastole to reverse to the hepatic pain. So those are the signs of a constriction pericarditis by echo. Now, final thoughts about like the new guidelines. New guidelines, I think like simplifies everything about like a pericardial disease. Remember, pericardial disease, you have acute pericarditis. How you diagnose acute pericarditis based on the new guidelines compared to the 2015 European guidelines is you need to have like a characteristic chest pain for pericardial disease, such as like chest pain is sharp, improve with leaning forward, in pleuritic, worse with inspiration. You have that. You need like at least one criteria to consider at least likely and two criteria to consider like definite. So you are gonna always ask in the emergency department labs, CRP, ESR, CBC to see like elevation CRP, elevation like ESR, inflammatory markers, that's only 1 point. Always EKG to see like that's the specific time, PR depressions, ST elevations, LSWL, and always echocardiogram to see like pericardial effusion. And always don't forget troponins. Why? Because that tell you like a myocardium involvement. When you ask always echocardiogram, I will recommend to order like a strain, global longitudinal strain, because that can tell you like involvement of the myocardium. Based on this, initially you can have like a diagnosis. A physical exam, pericardial rub, you can do it, but it's difficult to hear. Then, if the diagnosis is in doubt or there is any complications, consider cardiac MRI. CT or the scan when you have other causes of chest pain that are not clear or you suspect any calcification of the pericardium. Then, for the management, first-time management, always NSAIDs, aspirin for symptomatic management until the symptoms resolve. What is the doses? Aspirin 1,000 3 times daily, or ibuprofen 6 to 800 3 times daily. Colchicine 0.6 twice a day, daily only when the patient is less than 70 kilograms or the patient has like severe renal or liver impairment. Exercise always recommended less than 100 beats per minute. Why is it important? Because it's going to cause less rubbing of the pericardium, less inflammation. Imagine the patient has like atrial fibrillation, rate control, please make sure like the heart rate doesn't increase more than 100. Then, if those therapies don't improve, consider anti-interleukin 1, especially when you have like inflammation, elevation of like markers. If you don't have inflammation, you may consider steroids. Steroid, remember, is prednisone 0.2 to 0.5 milligram kilogram daily. If you are going to use more than 20 milligrams of prednisone daily, consider prophylaxis for PCP, pneumatosis, or osteoporosis. Then, if nothing of those works, pericardiectomy. Pericardiectomy only in like a high volume centers for that. Patient going to pregnancy, consider pericardiectomy. Why? Because you don't want those medications to affect the fetus. So this is everything that I have. Please leave comments below and tell me which guidelines you would like to talk next. Thank you. Bye bye.